Our next session is on addressing inequality with vulnerable populations, and this session will be moderated by Dr. Amina Abu Bakr, who has many affiliations, and the one I'm going to mention is the Wellcome Trust Research Program in Kenya. Dr. Abu Bakr, please. Yeah, keep going.
Thank you very much. It's my pleasure to invite you for this last session. It's a session on vulnerable children, and it really does continue from the previous discussion. You know, we have talked about children of immigrant background. We have talked about children who are HIV infected, and all these are vulnerable populations. And this is an interesting topic, because the most needy in the society rarely get the services they need. So we have 3 speakers for this session. The first speaker, Dr. Nicholas Barnett, the Managing Director at Results for Development, will focus really on the discussion on whether to target or to have a more universal program. Welcome.
I need my presentation, and not the Australian one. Thank you very much. Great. So thank you very much. So I want to focus particularly on the question about how you get resources to programs for the vulnerable and disadvantaged, because resources are limited. And of course, one of the ways to do this is through targeting. The basic problem, of course, is nothing new. Been stated already in many, many different ways. Those most likely to benefit from early childhood programs are actually those least likely to be participating in them. And a second point is that governments either can't or believe they can't finance these programs. So part of the answer, and I want to stress only part of the answer, is to target the resources, to target them on the poor and vulnerable. So briefly, what I want to do is just run over a few straightforward aspects of this. It may be fairly basic, but the reason I want to do it is I think it actually has got some quite important implications for our broader theme of integrated versus coordinated services. So I've seen that in the first of these fora, first workshop rather of this forum, you had some discussion perhaps about this whole question of public obligation, universal programs versus targeted programs and so on. But I think the important question, which does need some thinking about, is whether or not targeted programs are politically acceptable in whatever context you are in. And the answer may be different in different places, but there are also technical answers to that, as well as political feasibility answers, but especially around the question whether it's actually cost-effective to have universal programs when universally provided programs when some of the better off portions of the community can afford to purchase their own services, what the impact is on the poorer households, and so on. Similarly, there are targeted programs also having questions around them actually about whether you can actually do it. And again, this may depend on the particular context. Then there are important questions about the trade-off between equity and efficiency, as well as the questions about the trade-offs between universalism and targeting. And finally, which is not our subject today, but I just want to touch on it for a second because it's quite interesting, that it does seem that there are actually some differences on the quality, or at least judging for some evidence from kindergarten programs. There are some differences on program quality according to whether the programs are universal or are targeted. These differences being that, which perhaps are not so surprising, but they slightly surprised me, that the universal programs are much better in the sense of they're more structured, they have more formally qualified teachers, caregivers, and so on. The hours and so on are more formal. Whereas the targeted programs tend to be looser, but at the same time to have higher quality of interaction between the children, among the children, and between the children and the caregivers. Although, interestingly, these comparisons also seem to show no ultimate difference in terms of achievement by the children, but maybe that, so there are some questions what is actually being measured there also. How might targeting be done? How is it done? Well, it can be done in many ways, of course. The simplest way to do it, and this is very relevant here, is to target your program using some sort of criteria that already exist in the context in which you are. That is the simplest. The two typically most used are geographic targeting and income targeting. There can, of course, be, and there are other ways, you know, we just heard about ethnic, well, not ethnic targeting, but ethnic groups or linguistic groups and that sort of thing. But these two most common types. But a very key point that is often forgotten is the need to also validate at the local level something which may be determined at a national level, but to validate even at the specific household level that in fact the criteria are being met. I want to suggest that there are two ways of targeting which are important for us to think about. One is financial targeting, which is basically putting actual money or at least purchasing power into the hands of poor families so that they can access ECD services of various types. And there are some quite well-known examples of this, like conditional cash transfers, and there are also perhaps some not so well-known examples of this, like family allowances in Mali or the voucher schemes in Switzerland. I don't, unfortunately, given time, have the opportunity to go into all of that, but the point I want to make is that there's quite a wide range of things in quite a wide range of countries. The other main type of targeting, of course, is through actual delivery, who you deliver to, not providing the money to the children, but providing the actual service to the children. So here again, there are quite a lot of examples of different types of things which have been reasonably successful in different contexts. We're under the usual time pressure, so I won't go into details, but I'd be happy to discuss some of these with anybody individually afterwards who would like to know something about them if they don't know something about them. Some of them, of course, very well known, like ICDS in India or the Turkey program, perhaps some others not so well known. The main points I want to, and I want to conclude here because I think this is where the messages are for this, this particular workshop. There is this issue about whether or not there's consensus, which has to be dealt with in each context. There's a particular problem, even if there is an agreement to do targeting, whether you can actually do it, whether you've got the data that you need for it. But the main point I want to make is, and we have seen some examples of this. I'm only aware of some examples interestingly, from some high-income countries, but I expect there are examples from low and lower middle-income countries, but I haven't had the time to find them. Anyway, examples where there is quite inconsistent targeting across health programs and education programs and so on, which actually can be quite a problem. So this is the main point I wanted to get over for this workshop. Thank you very much.
Thank you. So our next presenter is Dr. Claire Rusenman. She's a consultant at the Australian Nurse Family Partnership Program. She'll present a case study. Actually, that's why we changed the program a bit to allow for an overview. Then the next two will be case studies.
Okay, well, thank you all for hanging in there for the last session. One of the things that I've taken from today and all the presentations today is that the challenges of implementing programs with fidelity to evidence are very similar in high-income countries as they are in low-income countries. So a lot of the things that I will say will actually be revisiting some of the ground that's been fairly well travelled today, and I can talk a little bit about how the Nurse Family Partnership Program in Australia has addressed some of those challenges. Firstly, what is the Nurse Family Partnership Program? Very briefly, it's a program of home visiting over 30 months. A nurse visits a family for 30 months, and that nurse is supported by 64 detailed descriptions of home visits. So they get a set of guidelines which actually outlines what they're going to do in all those 64 visits. And then the nurse can use her own clinical judgment to adapt those individual visits to their particular client. And obviously different clients have very different needs in relation to any particular topic. And the expert nurses in our program have told me that, particularly the ones who've been working in child and maternal health for a very long time, that they've worked in programs which have asked them to do what this program asked them to do before, but they've never been told how to do it. And this actually tells them how to do this thing that they've been asked to do. The second aspects of the program is that it's based on randomised controlled trials, which Dr. Olds began over 30 years ago. So there's over 30 years now of evidence around what works and evidence going into the second generation of the children of the people who have initially been part of the program. And the evidence from those randomised controlled trials have now formed part of the licence for the program. So the licence includes a commitment to follow through with 18 program elements, and those 18 elements relate to the evidence around that were developed. The other, I guess, critical aspect is that for each client in the program, about 30 data points are collected throughout those 64 visits. So there's a lot of data for each person, which lends itself to very strong program evaluations over time. Thirdly, very strong theoretical platforms underpinning the program. None of these are unique to the Nurse Family Partnership Program. It's well known that Bronfenbrenner's theory, Bandura's theory, Balby's theories are not by any means unique in and of themselves. But I think what is unique to this program is how those are brought together and how they're woven together within a sort of nursing framework that this program delivers. And fourthly, I guess, the client-centred principles. There are 5 client-centred principles and a very strong model of change about what is it about what the nurse is doing that's going to change the outcome for the child. And those 5 client-centred principles are around maternal health, child health, life chances, life life course development, etc. So looking then, I've got to go through this so quickly, it's very difficult to summarise it. Looking at the Australian program, I guess coming on first to Nick's point about targeting, we dealt with that by basically providing a universal program to a very small group of people. So it's universal to pregnant women who are pregnant with an Aboriginal and Torres Strait Islander child in Australia, in the particular sites where the program is being rolled out. And one of the unique elements of the program, I guess, is that it runs out of community-controlled Aboriginal health services. One of the very important elements that is in the fidelity elements is that the program must be run by an organisation which has very strong links to the community, is trusted by the community, and basically an organisation that people will trust and go to. So in Australia, we have 3 tiers of government, which make rolling out any program incredibly difficult because there's huge opportunities for cost shifting between different levels of government. The community-controlled health services are funded by the national government, the Australian government. Other health services are funded by state governments. So the cost of running it out through community-controlled health services is that those health services may not have as strong links to state-run programs, which may be required for referral purposes as other organisations might be. But one of the advantages of doing that is that this program can assist those organisations to make those links for other programs as well. So there are implications in relation to that. The policy context, we have a bipartisan commitment to close the gap between in various areas of disadvantage for Indigenous people in Australia, between Indigenous and non-Indigenous people. Maternal and child health indicators are in that gap, as are mortality indicators for both children and adults. So there is bipartisan support. It varies, of course, in terms of whichever government's in, whether the program expands or doesn't expand. But nevertheless, that provides a very strong foundation for the program survival and for rolling out the program. I guess in terms of the key adaptations, there were 2 specific key adaptations which were made in the Australian context. One was that the community-controlled organisations which were approached about investing in this program insisted that if the program was going to be run through their organisations, Indigenous people must be involved in it. And as you know, one of the elements, fidelity elements, is that it must be a nurse-run program. And there are not very many Indigenous nurses in Australia. So we have an extra worker who's called a family partnership worker who works with the nurse in this program, liaises with the clients, introduces the nurse to the client in the first instance, and stays in the visits until she and the client are happy that the relationship is a strong relationship, and then she will withdraw and the program goes ahead with the nurse, with the dyad, as it was originally intended to. Scalability. I guess essentially I'd sort of make the same point as Dr. Berta made earlier, that really for scalability we need to be methodical. We need to be intentional about how we do our scalability. It needs to be iterative. We need to be keeping going back and looking at it and working out what's working and what's not. And we need to be informed by data. Having said that, I'd also say that there's never enough data. For government, there's never enough data. And so there also is a question of to what extent do you invest in the data which will often be used to make decisions that people want to make anyway. And so data is very important, but it's also one mustn't put too much faith in it, I suppose. There are a large number of policies, tools, systems that are shared international, which I don't really have time to go into, but I think those policy systems and tools and ways of planning the program are exactly what makes it scalable. And it is those things and the guidance that are obtained from those things. The huge challenge, of course, is workforce, and that's been mentioned before. And in our case, we have affluent society. We've got highly trained nurses, always with degrees and postgraduate qualifications. What we find in terms of this program is that we start by having to get those nurses to unlearn the skills that they've learnt as hospital nurses often. We don't have a strong home visiting history in Australia, so we don't have a lot of nurses in the program who've done home visiting before. They have to unlearn a lot of their skills and relearn relationship-based skills. And in relation to having the Indigenous workers on the program, we have developed a program of which, again, I can talk to people in more detail about. I think it's one of the more important things we've done. Developed a training program which is based around microcommunication skills. It's based around, we have things like car talk, where they actually role play. You know, you've just been to a home visit with a nurse who's been rude to the clients in terms of the cultural acceptability of the household that they've gone into. They've done the wrong thing. How are you going to tell them that? That's not an easy thing to do. That's not something that you just say to them, oh, look, you just sort it out, tell them how to be culturally appropriate, and then we don't have to worry about it anymore. Those things are really hard skills, and that's something we put a lot of work into, is how you actually get that communication going and get open dialogue and willingness to reflect in a non-defensive manner about some of those issues. So those have been, I think, quite successful. And finally, just to look at sustainability. Oh, sorry. In Australia, sustainability is definitely not about the money. We're a rich country. If you looked at the sort of political rhetoric, you wouldn't always think we were a rich country because, you know, there's always doom and gloom and we're always about to go broke and, you know. But the fact of the matter is that we are an affluent country. We spend hundreds of billions of dollars on programs that don't work. I don't believe that anybody would even dispute that. I think everybody knows that they don't work. There's a lot of concerns whenever issues are raised about evidence-based funding that means you have to defund someone, and that's not politically very sort of acceptable, and so we can't really go there, and we're still going to keep funding them even though we know that they don't work. So those are questions, and the Australian Medical Association in Australia is now starting to try to change the discourse around that sort of issue. But the other thing that's really exciting to us is that the community-controlled health services who are running this program are starting to change the discourse, and they are the ones that are now arguing for evidence-based programs. They want funding in their communities, so the demand is coming bottom up for evidence-based programming, and that I think is really exciting and something that we're very pleased with. So to finish up, I guess one of the things I'd say that is one of the benefits of this program is that it has helped us to slow everything down. By getting a licensed program from overseas and being able to say, no, I'm sorry, we can't do this in a month because we've got to go through these steps, and no, we can't avoid that because it's part of the licence, that's actually been quite helpful for us in terms of negotiating with government demands or imperatives to have outcomes quickly. So it can take years to get contracts signed to do a program, but once it's signed to do it, you need to have an outcome next week. You need to have your first clients on board and your reporting. And I think having that external evidence-based sort of thing that we can point to say no, we have to do it this way, has been very helpful for people inside the program who are trying to do things properly and trying to build the efficacy among the staff and clients in the program so that they can exercise their judgment and can adapt the program to meet their needs without needing to change the evidence-based elements of the program. So that's just one point I wanted to make. The other one is that innovation is part of the deal. I think often with governments, when they have agreed to fund something, they think that's the end of it. Like, we're buying this thing, we'll buy it and then everything will be better, rather than knowing that actually you need to commit to a process of innovation, which is in our case, an international process of innovation, which means that we have to send data to the international group, and they will then be developing new tools, new ways of doing things, looking at the evidence that all you guys are presenting, and incorporating that into the program. So the program is never an end in itself. The program is always changing, dynamic, and moving forward. And that's something I think that sometimes it's not easy to sell to governments who want to buy a solution that will be the solution forever. So that's all I wanted to say for now. Thank you.
Thank you very much. It's my pleasure to invite the last speaker for the day, Dr. Kalana from Plan International. He'll present work from Sri Lanka with rural and children from a rural area who have experienced conflict. Welcome.
Being the last speaker of the day and having to listen to all the presentations that were made today, I'm probably the most enriched speaker in this forum. So I have many, many things to talk about. So remind me of the time, Amina. And when it comes to Sri Lanka, it's considered an outlier in South Asia because all the traditional health indicators are better. Maternal mortality, infant mortality, facility delivery, stillbirth attendance, everything is over 90%. Immunization, coverage, everything 90%. But I'm going to talk about an intervention we did with 135 village settings in what we call remote rural areas in Sri Lanka. And my presentation today will focus on 77 out of the 135 which were really affected by the conflict, 30-year conflict. They were not really the directly affected communities. Directly the conflict was here, but the communities which were margining the conflict-affected areas are the focus of today's discussion. So this was area bordering armed conflict characterized by nighttime displacement, sporadic terrorist attacks on civilians, and disruption of livelihoods. We started the intervention about 1 year after the conflict. So it was a post-conflict setting where the community cohesion and community spirit wasn't there because community was isolated and for so long. And there were slightly more than 3,800 children under the age of 5 in these 77 communities. And interestingly, even during the conflict, what was continuing was the health services. The health services were there functioning, and community midwives were visiting the communities even with hardships. And still, if you take the skilled birth attendance or facility deliveries were 99%. Immunization was 99%, even with the conflict. But when we looked at the at these 3,800 children, percentage of children who were underweight was 64%. In most of the, the 135 villages, if we take, it was 45% percentage of children who were underweight, especially the 2 to 5 year age group. And girls and boys were equally affected. And the other 36% were also not safe. Like the population of underweight children were dynamic, because all the time, from these 36%, all the time, new children were getting added up to the cohort of children who were already undernourished. And livelihood and the other characteristics are like typical of a rural poor community. Average education of both men and women were lower. And the situation was like 90% of the mothers had exclusively breastfed their children for 6 months. But diets were undiversified. Maternal and child care practices were found to be really at stake. But health-seeking behavior was good, and access to health care was good. So we thought like there is no new evidence that we have to generate. We just had to put the remaining prevailing evidence into practice. We thought it's simple because we knew what we wanted to do from, sources including but not limited to Essential Nutrition Action, Lancet series, etc., etc., etc. Because we had all the evidence in the world about what to do. And how to do, the panacea was educate parents, parenting education, educate on exclusive breastfeeding, educate on how to make a diversified diet, what percentage of carbohydrates, what percentage of lipids, so that was what the primary healthcare system was doing. Because they have public health midwives, as we call it. They are really community midwives who are not expected to do deliveries much because institutional deliveries were 99%. But they were expected to go out to the communities, visit homes and engage with the communities. But all what they were doing was preaching. And there was a lot of supplementation going on. But there was a glass wall that, like, if you talk without this mic, the people who are in the translation cubicle will not hear us. So the translation will not happen. So like that, even when the health workers spent their time, energy, and resources on educating people, there was a glass wall preventing this education and improved knowledge from translating into action or practices or behavior. One really big factor was overloaded women's workload, because they have to do they had an economic role, they had to do all the household work, childcare, and on top of that, there was a high prevalence of domestic violence. And they had really little time for recreation, and their mental well-being was so poor. And they themselves were either undernourished or overnourished. And then there was, there was no like significant food security issue, like without lack of food. But there was a utilization issue where researchers highlighted the effect of, like, there were good diverse diets available, but people were selling it to the shops and buying commercial products, which indicated a value, social value towards, commercially available, processed, advertised food. And there was some extent of myths and misconceptions about food. And a really big factor was that the control of finances in the household was with men. And they spent a lot of money on alcohol and smoking. And even the income that was generated by their wives was spent on this. And due to the long period of conflict, they were really lacking aspirations for their children and their families. For this, we didn't have any sachet or vaccine. If we were actually, when we presented this, people were looking for sachets, especially the private sector. They were trying to produce a sachet where you give a powder to men and they were not violent, right? Literally, okay? But we didn't have it. So only solution was a social transformation approach. So we needed to change household practices. Nothing else would change what children were getting. And to change household practices, unlike in unlike in societies where families live in isolation, these were collectivist communities where people, other neighbors had greater influence on what happens in a household. So you needed to change the neighbors and the community. And how do we do that? Do we have a vaccine? No. To change the community. This was our intervention logic. We needed to have a community-led action, collective action to change people. I think Emily mentioned this. Communities have potential to do collective action and change societies, and we need to harness that. And the greatest factor that we opted to address is the attitudes and skills of the already prevailing community midwives who were mandated to do this task, and to make them more skillful and have more favorable attitudes towards engaging people and enabling people to come up with their own action to address their own problems. So we started this program with the Foundation for Health Promotion, Ministry of Health and Rajarat University of Sri Lanka, spanning from 2010 to 12. And it was really to bring out the community action. And key features were that these were entirely owned by the communities. The action was not prescribed. They own it. And they were not outside daily events, outside of their daily routines. They were not events. They were embedded in their daily routines. And ultimately we found that they were contagious because they were so interesting, easy to do, and produce result. The neighbors took it up more easily. And communities themselves monitored the change, and process was very interesting. And this is a very good example of changing of aspirations among mothers. This mother imagined her child's brain like a beehive, and the amount of interaction she and her child and her father had with each other, she imagined it to be like bees filling the hive with honey. And she got her child to fill up each kind of cavity with color whenever she felt that my father and mother did something for me that was made me happy. And that really sums up the change in the mindset of people. And they created what they call baby rooms, but we renamed it as baby corners because some of the houses hardly had any room. They were having one space for the entire family to cook, sleep, and everything. So these were they call it feeding the five senses. So it's creating and stimulating environment inside and outside the house for the child's well-being and development. And I particularly chose this picture because this is child's playhouse and this is their own kitchen. So I think it's child's house is better than their own house. And they were, contagious. As 5 families would start it, and when you go 1 month after, you see the whole community is doing it. When you go on the road walking, you will see every household that has a child under 5 years have a playhouse, with dangling things like glittering things. So it's very visible. And group playhouses, this is as a remedy for workload issue. They got together, and families, neighborhoods, like 5 families, 10 families got together and give their children a chance to play together and eat together. And then they soon realize that when the children are together, they ate more. And even the things that they never ate at home, they were eating. And yeah, and then they invented the tool called happiness calendar to stimulate change in gender relations. What you can't see is the gender relations part. So I don't have time to explain each tool, but the result was amazing. 64% came down to 28% in just 2 years. And I don't deny the fact that the end of conflict was playing a role in this, remarkable change, because people's livelihoods change and all that. But when we haven't compared it statistically with the areas where there was no conflict, but to general, when you do a general analysis, you could see that there is no difference. There was very remarkable difference in the conflict areas, post-conflict areas, but there were, similar changes in the non-conflict areas. Yeah, it's one of the things that we need to take forward when we think of the future of this program. And diversity scores came up. Median number of, median time spent with children came up. Low birth weight came down by half. And underweight among the preschoolers came up. And this is two of over 3,000 growth charts where you see like they were going on the red zone, -3 SD, came up and came to this thing. And this was being captured by one of the UNICEF studies later on. But challenges. Community midwives at first did not believe that the communities have the potential to transform their own environment. So we had to do some convincing. But there was the participation of the midwives was entirely voluntary. They were not forced, or they were not measured on the performance. And finally, like, replication is a challenge because there is no pill. This is not an invention of a pill where you invent a pill and then give it to each and everybody with the same symptom and they will get better. It's not like that, because each community is different, each household is different, so you have to customize. So there is a great deal of customization, but yet UNICEF and the government of Sri Lanka took up partnered with Plan in Sri Lanka to expand this into 9,000 communities. But the government changed, but I moved to Laos. So I don't know what's the progress about the program now, but I'm hopeful that this will be replicated, or like, even replication is not a good word, but will be expanded to 9,000 communities at least. And as I said, more research, more robust research is needed for this to be, become a pill of some sort, if at all. So, and this proved us that bottom-up approaches work, and also when this is being implemented in other areas, I think the soft elements need to be taken into account, like how the facilitation is done, how the engagement of communities is done. And there was a health promotion facilitator to mentor the public health midwife, and the idea is to phase them out and place them in other areas when the midwives are fully competent in doing it. And thank you very much.
Hi. So we've gone ahead of time a little bit. He asked an African to remind him of time, and that didn't work very well. But anyway, so we have around 17 minutes to take some questions. I will start with the floor, but I'll encourage those online who have questions to send us questions. So any questions from the floor? So we'll start from there, then Pia.
Yeah, thank you very much. All three were really exciting, wonderful presentations. I had a question specifically for Dr. Kalana. Thank you. Thank you very much for raising the issue of social norms and the measurability of social norms, and and how scalability is possible with some of the soft factors. So I think those messages came through quite clearly. But my question was, since there was so much focus on gender within the intervention, to what extent were fathers involved, and was there any measure of behavior change or even attitude change with fathers? Thank you.
Maybe we can take this question, then.
Okay. All right, great. Yeah, thanks for the panel. I know it was the last one, but you kept us going, and it was great to end on your with your presentation, Dr. Kalana. Give us hope. My question is for Nick. I agree that we don't have consensus on whether we should be targeting and how we should be targeting. It is a very big question, I think, in the field of early childhood we have to answer. And we see a sort of a range really of possibilities. And I don't know, I mean, I think you presented some very general ways of thinking about targeting. But I don't know if there's something we should as a field be looking at and prioritizing to help us make this decision and then come out with some sort of a recommendation, because this is an area that we have to tackle. And either because of issues of exclusion, we don't look at it, and or because we don't have the science right that really helps us set up targeting in a manner that is leading to outcomes. I'm not sure where all the problem areas lie. But I think the time has come for us to be quite clear with the recommendations as to what the field's position is on this. So it would be good to know if you think we're ready to make that sort of a recommendation and what it should be.
So I will read out a question from Laurentian. And she's inquiring if there have been any programs particularly targeted at fathers, and if we are missing something by focusing mainly on mothers. So I think Dr. Kalana or Claire, one of you could take that question.
About the question of fathers' involvement, I think I've not elaborated on some of the key elements of the program because of time, because that is one of the greatest things that we've seen, especially with the invention of the happiness calendars, as well as there were like fathers groups who were mobilizing other fathers for transformation. And we see a lot of fathers, almost in almost all communities, the gender roles have been changed because there is more household work sharing now. And with the invention of the happiness calendar, what was realized by the fathers was that when they engaged in childcare and household work, their sense of happiness improved. That was a self-realization. And that made them to advocate with the other fathers to get involved in such things, and also them sticking to it. And the whole community spirit changing, like even if earlier, even if there was a father who wanted to get involved and help their wives more, they couldn't do it because mother-in-laws and the neighbors or the father's friends wouldn't allow it, because they would ask, why are you doing women's work? You are a man or a woman. And they were, but since these were questioned in community forums, then even the people who were, the fathers who were feeling comfortable in doing it increased, and that ensured that they continued it for a long time. And there is a lot of transformation, and I only highlighted the things that are, that can be highlighted colorfully. But there were a lot of group activities, collective action that was going on in the communities to engage fathers, change how women themselves perceive their role, and what the role of the father be, and that kind of thing. Yeah.
The question about where we are in the field on targeting, I think we're not quite ready, but we are getting close. But I'm not the leading expert on this in any way. I just wanted to get this topic onto the agenda because I hadn't quite seen it there. My sense is that we have a lot of information, but we haven't systematically put it together. So I would think that, you know, some type of systematic review or something like that might be an appropriate thing to do. That's the first point. The second point is I think we need to know a bit more about what is, and I sort of began to allude to that, what is possible in low data situations. You know, we can go around saying we need more data, fine. But we've also got to deal with the kind of situations we're actually in. And I don't think anybody's really kind of looked at that question in that way. So I think there is a need for some sort of, not a you know, 5 years of experiments or something, but more looking at a lot of the information we already have from some somewhat different angles.
I'd like to respond to two questions. One is the targeting question, and I think that's an interesting issue in terms of the flip side of stigma and how targeting can be related to that. And I guess we found in our program that if members of the community and the clients understand the program well enough, they will self-select for the programs that they need. And sure, some people do get services, I suppose, that more vulnerable people might benefit from more. But people don't stay in programs where they're not getting benefit. So it's that's one way of looking at it as well. In terms of the fathers, that's something that we've had enormous fun with, I guess, in the program, in the sense that with Aboriginal and Torres Strait Islander Australians, there's a very strict division between men's and women's business. It's one of the critical cultural divides, and in the site where we have, I guess, the largest proportion of people who are the most traditional and have strongest links with their traditional heritage, we have a grandmothers group that advises the program, and that grandmothers group is there when, for example, a client might want the father to be at the birth of the child, but the grandmother's group and the would be vehemently opposed to that, traditionally that not being appropriate. And there have been some marvellous discussions, and I think it's because of the openness of the nurses in the program, and because it's a community-controlled health service, people trust the program and they're willing to come in. And there have been marvellous discussions between the nurses and the grandmothers about the evidence and what is evidence-based, what's preference, to what degree living cultures change and take on new ideas and new evidence. And the grandmothers are actually very willing to listen and to provide clients, if they're invited to come in to talk to a client, provide clients with traditional knowledge and traditional ideas and views, fully in the recognition that the client has the right to make their own choice and that they will be provided with other views and that these, the client will decide these things. So fathers have been brought in fact, in the program a lot more than they would have been without that, I guess, approach of the program, which is all around reflection. The other thing is that with the family partnership workers in the program, and it highlights the importance of the family partnership workers who are able to talk to fathers. Fathers can attend the home visits as well if they wish, and they do often. And many of the fathers have in fact asked nurses for referrals to violence programs and alcohol and drug programs and that sort of thing. Once they've heard about the implications of violence in the family for children, they will ask the nurses, for help. And even though it's outside the program, the nurses will assist them. But in terms of things like cultural issues around fathers or other members of the family controlling income and that sort of thing, the family partnership workers have gone in and talked to families about the fact that it is okay for pregnant women to actually keep the payments that are for their babies, whereas the families would definitely not have listened to nurses, white nurses who told them that. But family partnership workers will go in and say, actually, culturally, this is okay. They're allowed to do that. They can do this. It's in the best interest of their child, and this is okay, and negotiate some of those issues. So it's a complicated issue, and one that I think will be different in every society and for every culture. But openness and honesty is sort of paramount, really.
Thank you. Kimba and then Angela. I don't know if there's any other question. We have a few minutes, so I'll take all the questions. Yeah? Oh, you don't have a question? Sorry.
I just have a quick, perhaps, thing to throw on the universal versus targeted agenda, which would be if there were a consensus around targeted, then where do you draw the line? So do you draw, if it's means tested, geographical is probably much easier. So do you draw the line at the very, very extreme poor? I was intrigued by Jens's presentation and comment of basic essential services for all children, which argues for a universal approach. And I don't think that would exclude adding a layer onto that of a targeted approach. So I would just throw that perhaps onto a research agenda.
Anyone would like to comment on that?
If I could just make a quick comment on that. I mean, I think that's right from a theoretical point of view. The practical question is that we all know it's extremely hard to get any services, targeted or not, to the very poorest. And so what do we mean by this? I mean, can we even find the very poorest and this sort of thing? So it actually has an important practical as well as policy element to it.
So we have only 4 minutes. Any quick questions? Okay, I think we... Oh, yeah?
Since we do have the time, just a quick remark about the targeting. I remember in Georgia, the UNICEF was campaigning for a child benefit scheme, and they advocated for no targeting at all, just give it to everybody. And they did it after very careful consideration, a lot of research, and they found that if you target, there's so much mistargeting. People who get it, who shouldn't get it, and vice versa. And they said it's better to accept that some people get it while they don't really need it. In Macedonia, I saw that actually, a lot of mistargeting. And these are countries where most people have a job or they're in the social system somehow. And I remember in Kenya, where this is not the case, a data-poor country, there was a scheme for orphans and vulnerable children, and it was based on proxy measures, like is there a television in the home, yes or no, how many people, etc. That's very sensitive to cheating. I mean, you just put the television away and then you get, right? So generally speaking, it's rather difficult. And about the fathers, now I'm talking anyway, in Timor-Leste, which is in the region, so it seems that involving fathers reduces domestic violence, not just against the children, but also the mothers. So I totally agree with the very general beneficial impact of involving fathers. Thank you.
So, may I ask you to join me in thanking the speakers and also clapping for yourselves?